Jack. All right, so moving on, Sheena Kalagara is the other student who did her scholarly year in our department. She was mentored by Dr. Kellner. She completed her undergraduate degree at Brown before coming to Mount Sinai, studying biology there. And so she'll be discussing her work with Dr. Kellner with us today.
Thank you. Thank you, everyone, and great presentation, Jack. Today I'm going to be talking about the work that I did over my scholarly year, and my presentation is titled Innovations in Neurosurgery, VALOR and LUMEN. And so here is an outline for my talk today. The two major projects that I'm going to be speaking about relate to vagus nerve stimulation for stroke rehabilitation, through which we did a safety profile characterization of VNS. We created the VALOR registry, and we had a novel patient application. And the second project is a collaboration that I did with Biodesign called the LUMEN project. And the three phases of this include the needs and strategy development, prototyping and experimentation, and then our participation in the most recent cohort of the National Icahn. So starting off with our vagus nerve stimulation work, the interest in this kind of began with the Dawson paper, which was written in 2021, in which they used vagus nerve stimulation for ischemic stroke rehabilitation. So in this study, they enrolled 108 patients, 53 into the intervention group, 55 into the control group. And notably, the time since these patient strokes was on average about 3 years, which is a unique concept because this is outside of the critical, usually acute window for regaining function after a stroke. So here's the methods of which the intervention was completed. They had 6 weeks of in-clinic therapy with vagus nerve stimulation provided during the therapy exercises by a clinician or a therapist. And their primary outcome was looking at changes in Fugel-Meyer assessment, upper extremity scores on the first day after completing the 6-week in-clinic therapy sessions. And here are the major conclusions that they saw. They saw that twice as many members of the intervention group achieved clinically meaningful improvements in upper limb impairments, and the improvements were noted outside of the classic window for stroke rehabilitation. So this kind of brings us to the goal of our project on how we can incorporate vagus nerve stimulation for stroke rehabilitation into practice here at Sinai. So the first step of this was performing a safety profile characterization. So whenever we're using a new treatment or a treatment for a new indication, it's important to understand the range of side effects that can happen in order to provide informed consent for patients and also for what to expect from the clinician side. So we went ahead and conducted a systematic review. We were essentially including any RCTs which had a main intervention of an implanted vagus nerve therapy in adult patients. And so here are the results of what we found. We found that the topmost 15 common complications are listed on the left, and our main conclusions were that the complications associated with this procedure are both mild and transient, and the majority of them are either related to the implantation procedure itself or the device stimulation. And overall, this led us to believe that VNS remains a promising management option for treatment-resistant disease processes. So then this kind of leads us to creating our own registry here at Sinai called the VALOR registry. So here's the design of the registry that we created. There are 3 key players. So the ARC team, Abilities Research Center team, the Neurosurgery team, and then the clinical research team. In general, the patients would present to the ARC team for their initial evaluation, and then would be transferred to the Neurosurgery team for surgical evaluation and their operative care. The 6 weeks of rehabilitation will be done by the ARC team, as well as they would perform the post-program assessments. And the clinical research team would be involved in creating the database and also data collection during this time. So far we have 10 patients that we have data on, and I wanted to share that with you all. So some of the key insights that we saw an improvement of 12 points on the Fugel-Meyer upper extremity scores at 6 weeks. And this compares to the 5 points in improvement that the Dawson team saw, which highlights the potential of this treatment. So the next thing I wanted to discuss was a novel patient application in which we used VNS. So we had a patient present here who had intercerebral hemorrhage, and we decided to use vagus nerve stimulation in their rehabilitation. So this was a 67-year-old man with a basal ganglia hemorrhage 3 years prior to enrollment in the study. And we saw an improvement of almost 14 points in their Fugel-Meyer scores, kind of highlighting the applicability for this treatment in intracerebral hemorrhage as well as ischemic stroke. So that's kind of a summary of the vagus nerve stimulation work that I completed. And next, I think we'll talk about my biodesign collaboration called LUMEN. So a little bit of intro into the biodesign process. There are 5 phases that each project kind of goes through: the needs phase, strategy, prototyping, technology, and the product phase. And today I'll be mainly discussing these first 3 phases, which is what I completed over this course of this year. So the first phase is the needs phase, and we asked 4 key questions during this phase. 1, what is the current target population? 2, what is the current state of treatments that are offered? What are the major mechanisms of this new technology, and who are the major competitors that currently exist in this space? So we selected neurodegenerative disease as kind of our main overarching pathology that we wanted to target. And the reason for this is that it has a very high incidence, as you can see here, almost 2 million adults diagnosed annually, which we only expect to increase with an aging population. And the selected model disease that we chose was Alzheimer's disease because it has significant market potential. It has known implicated brain regions that may be able to be targeted by our technology, and it also has a well-studied pathophysiology. So the current treatments for Alzheimer's disease are shown here in this treatment algorithm. And the major issues here is that there are limited treatment options with disease progression, and these medications often don't have an underlying mechanism for neuroprotection. So the alternative treatment that we wanted to explore here was called photobiomodulation-based technology, or light therapy. So there are several key mechanisms when understanding PBM, and they're listed here. We can see increased energy availability, antioxidant properties, activation of neuroprotective genes, decreased inflammation, and increased cerebral blood flow. And these mechanisms are very broad and may serve and maybe the reason that they can serve such an important role in this potential disease process. So here are the current examples that are available in the market. These are all marketed as wellness devices looking to improve cognition, and they are all transcranial photobiomodulation-based devices, which kind of brings us to the 2 major limitations that are currently seen. First, we have limited penetration. Any light that's generated must travel through several layers of tissue and bone before reaching the target brain regions. Also, we have several design features, such as the effect might be limited by patient use and compliance. It can be affected by stigma as it's an external device, and there might be difficulty in accepting the diagnosis / need for treatment from the patient themselves. So that kind of summarizes the needs phase. And next we'll go on to strategy. So the 2 key questions that we're going to ask in the strategy phase include: what level of invasive treatment would patients be willing to undergo? And how can we balance this with light penetration to the key regions? And what experiments should be performed in the prototyping phase to determine the above? So during this year, we came up with 3 potential approaches that we could use. 1, the interparenchymal approach, the subdural approach, and the cranial approach. And here are the major considerations that we used when evaluating each of these 3 approaches. First is regarding the device details in terms of the invasiveness of the procedure versus light penetrance. The more invasive that you have a implant, such as the intraparenchymal implant, the higher light penetrance you can get to the key region, but this surgery would be much more invasive, as with the device. Next would be the ability to replace the device components, as we anticipate this device would be utilized for the lifetime of the patient. The next major category of things that we just considered were the biological effects. Whenever we're giving some kind of light therapy, we need to think about heat generation and how this heat will be dissipated, and also any potential tissue reactions that we could have in response to this treatment. So kind of taking all of this into consideration, we chose to go ahead with the cranial implant, with the major consideration in experimentation going to be the light penetrance that we're able to get, as this is the one that is furthest from the target regions in the brain. So this kind of brings us into our experimental workflow that we wanted to do going into the prototyping phase. And the one that I wanted to draw the most attention to was the cadaveric-based testing, in which we were using formalin-fixed brain in order to test light penetrance and also give us our proof of concept for this approach. So now we go on to the prototyping phase. So within the prototyping phase, there are two key milestones that need to be completed before you pass this step. The first milestone is, are we able to detect light penetrance with the current design to serve as a proof of concept? And the second milestone is, are we able to design a fully functional system with all of the major components of this device? So here's the device that we built. It has 3 LEDs at a wavelength of 850, and the emitting power is 140 milliwatts. Here's the experimental setup that we had with the photosensor on one side, the device on the other side, our formalin fixed brain tissue in the center. And here's the data that we generated. The first thing that we did was we built a theoretical model to see what our photosensor should have picked up. And then through empirical testing, we have our data on the right side. So we expected to see about 14.69 microwatts, and we got about 12 to 13 microwatts here detected from our experiments. So kind of putting this in context, we went back to the literature to see what the irradiance of currently used devices was. And keeping in mind that about 0.11% of this wavelength of light is transmitted through the scalp and the skull and associated tissues, we should be expecting around 60 microwatts of light penetrance. So compared to what we had, we were approximately at 22% of light transmittance. So kind of going back to the key tasks, while we do have our proof of concept completed that we are able to get some light penetrance through this tissue, this will be one of the major things going forward that we're trying to optimize, either with the use of either higher powered LEDs or the increased number of LEDs that we're using. And then this will bring us on to the current milestone that we're working on, which is developing a fully functional system with all the major components of this device. So the last part of this talk kind of looks into our participation in the National Science Foundation's Innovation Corps. So the National I Corps is a program that awards projects $50,000 to support both customer discovery and needs development and help accelerate research towards the goal of commercialization. And they tasked us with conducting about 100 interviews with key stakeholders over 7 weeks. At present, we've conducted 45 interviews, many of which have been with the department and residents here at Sinai. And here are the key insights that we got from this. The first of which being the underlying mechanism of PBM may be useful in treatment of neurological disease as it has anti-inflammatory properties and promotes neuroprotection. However, the potential for PBM to enact clinically meaningful change in cognitive disease is still unknown. And the major barrier that we got from these interviews was that seeking operative care in diseases that were previously treated with primarily medical management might be the biggest barrier that we will face in this development of our technology. So this kind of brings us to one of the major pivots that we've been considering, which uses the incorporation of PBM technology into cranioplasty implants to promote anti-inflammation and wound healing. And this is especially important as this would overcome the major barrier previously identified with the surgery already being performed and our technology being incorporated into this final step. So that was the presentation and work that I did over this past year. I wanted to acknowledge the great team here at Sinai. For the VALOR team, I worked with Dr. Kellner and Dr. Panov. And then for the LUMEN team, I worked with Dr. Kellner, who was the main PI. But of course, a lot of this work on the LUMEN side would not have been possible without Dr. Rappaport and the whole body design team, who were great in participating in ideation sessions and really helping bring the engineering portion of this along as well. And I really appreciate the opportunity to complete this work. Thank you.
Amazing presentation and work. Talk about drinking from a fire hose. Working with Kellner's got to be interesting. Chris, can you comment? I think you're on mute.
Can you hear me okay?
Yeah, now we can. Yeah.
There we go. Sheena, thank you. Great presentation and great work all year, and also great work since her first year. The VALOR project, actually, we began Sheena's first year, and she was instrumental putting that protocol together, wrote the protocol, and we began implementing that registry, and now we've gotten up to 10 patients, and that's the end of the translational pathway of device development to clinical application. And then she also this year got linked in with biodesign and worked intensely there at the first part of the translational pathway. So I really like how those two projects work together. in device development. Fantastic job.
Thank you.
I'll just echo that. It's a huge amount of work, and I think you did a terrific job. There's actually a lot more that Sheena did that obviously wasn't covered in this presentation. And if I could ask maybe one question, Sheena, is maybe two related questions. One is, any advice you may have to to other Mount Sinai medical students who are interested in device development and thinking about a scholarly year. We definitely have a number of them coming up, including Ian Ogden's this year. And relatedly, I think Chris and I and many of the other faculty members have noticed that when productive students move on in their careers, the work, if it can be passed from one student to another in one way or another, sometimes can continue. And especially with long-term projects like device development, I wonder if you may have any insight as to how those sort of links could be formed within the Mount Sinai medical student community.
Yeah, I think that's a great point. I think per your first question, I think one of the biggest things that I learned from this year in terms of device development was looking at the role of like perseverance and being able to pivot when you realize that something isn't working in the process. As you can see, I presented 3 of the approaches during the strategy phase, and each of these was like weeks to months of figuring out if it did work or didn't work and building the prototype. So I think it just takes a lot of perseverance, but also being flexible when you understand that there might be like a better way to approach your problem. And the second thought, looking at maybe the transition within medical school, I think the mentorship that I've gotten from older students and also students that have worked previously in brand design and having meetings with them was one of the biggest factors that I think goes along with like keeping the chain kind of in line with being able to pick up the kind of like what was previously done. And also I think brand design has a great process of keeping everything really organized. We use Monday to keep track of like what tasks have and have not been done. So I think all those really support like keeping this work going.
Roshini, would any of this been possible without the year off?
I honestly don't think so. I think that it is definitely possible to be able to do innovation work, but we at BioDesign, we have like weekly meetings. We have like Tuesdays in which we are having ideation sessions in order to kind of pitch what we're doing and have everyone give their thoughts. And I think you do need to be in the lab in order to conduct your experiments and all those things. So I really appreciate having this year off in order to do this work.
Oh, it's just amazing work. I know there are probably plenty of people who want to ask questions. Peter, do we have time or should we move on to the next?
I think we have a minute or two.
Jack, you had a question?
No, sorry. I meant to congratulate Sheena, but I accidentally raised my hand.
Okay.
Sheena, since I'm on speaker now. Congratulations. Awesome presentation.
Thank you.
Sheena, I can ask a quick question since we work together on a lot of this stuff. So I'm curious, VNS is sort of a mildly effective tool for almost everything, right? You do it for epilepsy, FDA approved for depression. Now we're doing it for stroke. So I'm curious your thoughts on the mechanism of VNS. Like, why do you think it works for all these things based on what we've done?
Yeah, I think that's a great question. I think the specific mechanisms are probably going to be elucidated with like a lot more like basic science research and those things. But I think overall, it probably relates to neuromodulators and being able to really strengthen these neural connections that happen after like an ischemic stroke or the intracerebral hemorrhage. And I think that that's probably kind of when you're connecting them to the in therapy exercises, I think this will really just help push this along and probably the reason why we saw such improvements in the Fiegel-Meyer scores.
It's just such wonderful work. The scholarly year has borne more fruit than we even anticipated. So I want to congratulate Roshina and Jack for having made the most of it.
Thank you.
Thank you.
All right, thank you guys. Next up, we're going to move on to neurocritical care pearls.